Next, I have the great honor to introduce one of our really close friends, Yoon Ha. Yoon visited us 11 years ago, I think, and was at this meeting actually 11 years ago when he spent, I think, a year total with us. Yoon came to see deformity surgery being done in neurosurgery, and has gone on to be a pioneer and really brought deformity surgery to neurosurgery in Korea, and become certainly now far beyond neurosurgery. He's become very well known and leader in deformity surgery in Asia and really around the world, and the Scoliosis Research Society as well. So Yoon, it's really great to have you. Yoon's been also a great supporter of our 4University meeting, which we have done before COVID and are reinvigorating. Looking forward to your talk on Parkinson's disease and ASD.
Thank you, Chris, for your warm introduction. So I'm very honored to share my clinical experience about the surgical management of spinal deformity in Parkinson's disease. My name is Yoon Ha from Yonsei University, Seoul, Korea. First of all, I really appreciate and I'd like to express sincere gratitude to both of Vdara and Chris for reactivating our 4University symposium. Oh, okay, so I have nothing to disclose related to this topic presentation, but as Chris told us that I have a very good memory in San Francisco in UCSF. At the time, I attended this meeting, year 2011, and I drew this artwork at the time, and I found it in my Facebook yesterday, and it's really a beautiful memory. I hope I will come back again in San Francisco and enjoy the meeting with all of you. So let me briefly introduce the Parkinson's disease. The Parkinson's disease was first described by James Parkinson, year 1817. At the time, James Parkinson described the Parkinson's disease as a shaking palsy, paralysis, agitance. It is a chronic neurodegenerative movement disorder affecting the voluntary as well as emotional movement. The prevalence of Parkinson's disease increased with aging. So pathology is very well known that decreasing the dopaminergic neuron in substantia nigra is the pathognomonic findings in Parkinson's disease. As you can see here in the Muhammad Ali, the famous superstar in boxing champion, he shows the typical characteristic symptoms of Parkinson's disease, such as hand tremor, rigidity, bradykinesia, and masked face, things like that. We can describe the Parkinson's disease symptom in the major features and minor features according to the responsiveness to the levodopa treatment. Usually major features such as resting tremor, bradykinesia, rigidity are relatively well responsive to the levodopa treatment. However, in minor features such as postural deformity, including spinal deformity, speech problem, depression, dysautonomia, all these kind of minor features are usually not responsive to the levodopa treatment. I investigate the prevalence and the incidence of Parkinson's disease in Korean population. This is the Korean National Health Registry database research. And we found that the prevalence and the incidence of Parkinson's disease is increasing according to following the years, because most of the developed countries are aging societies. So number of aged people increased. Therefore, number of the Parkinson's and other degenerative neuromuscular disorders are also increased. Also, I investigate the mortality of Parkinson's disease. We compare the mortality of Parkinson's disease patients versus age gender matched control population. We found that the significantly lower overall 10-year survival rate in Parkinson's disease patients compared to control population. Also, we investigate the effect of osteoporosis in terms of the mortality of the Parkinson's disease patients. Fortunately, there is no significant impact on the of osteoporosis on the Parkinson's disease mortality. However, when we perform the subgroup analysis with the Parkinson's disease and osteoporosis patient, whether who has a compression fracture or not, we can find a significantly decrease the overall survival rate in Parkinson's disease with osteoporosis and compression fracture. Therefore, when we have a patient in our outpatient clinic who has a Parkinson's disease and osteoporosis with a spine problem, we always have to teach and educate the patient and patient family about how much important the bone health of the patients. So it's really associated with the overall survival of the patients in Parkinson's disease. As we know, the Parkinson's disease patient has a higher prevalence of low back pain. There are many contributing factors, such as degeneration of descending dopaminergic pain pathways, and non-motor manifestations such as depression, anxiety, which lower the threshold of the pain perception, and the motor manifestations such as rigidity, impaired posture, hypokinesia. Those motor manifestations decrease the joint motion, joint movement. However, the repetitive joint movement may damage the joint, such as hyperkinesia, dyskinetic movement, increase the damage of the facet and disc spine. Also, generally, spine surgery outcomes in Parkinson's disease is considered poor because the Parkinson patient is generally old and poor bone quality and chronic movement disorder, muscle weakness, and inactivities. All those the risk factors are involving the poor surgical outcome in spine surgery in Parkinson's patients. We investigate the postoperative delirium in aged population. We performed the prospective study over 65 years old, and we enrolled 83 patients in our hospital. And we found that around 15% of lumbar surgery patients over 65 years old had experienced a postoperative delirium. We performed the multiple regression study, and we found that male Parkinson's disease patients, low cognitive functions such as lower mini-mental score, status exam scores, and admission to the ICU after the spine surgery. All these variables are associated with increased risk of postoperative delirium. So in my personal experience, male who has a Parkinson's disease, also Parkinson's patient, many patients develop the cognitive impairment during the disease natural course. And if patient need ICU admission after the deformity correction surgery, almost 100% of patients develop the postoperative delirium. Therefore, when we have a patient in our outpatient clinic to explain the surgery and the risk of complication, we always have to explain the risk of postoperative delirium in Parkinson's, especially in Parkinson's disease patients. Because the postoperative delirium in Parkinson's patients is usually severe and longer than the postoperative delirium in other general population group. We performed the single-level fusion surgery surgical outcome in Parkinson's disease patients. We investigated 20 patients in retrospective study. Interestingly, the preoperative back BAS score in millimeter scale was 53. But 2 years post-op BAS back millimeter scale is 55. Almost no improvement, even worse. Also, the fusion rate of this population is relatively lower. 75% of the patients have a successful bone fusion. But in this slide, you can see the complete fusion patients versus non-fusion patients. There's no meaningful difference in post-op 2 years BAS back scores, which means the fusion is not a major issue in post-operative back pain, especially in Parkinson's disease patients, because there are many other factors such as dyskinesia or increased kyphosis. All other variables are involving the development of post-operative back pain. So let me introduce the painful experience of my colleagues. I'm very thankful to my colleagues to share this educational case. And this 67-year-old female patient came to hospital because of severe back pain. Patient has a stage 2 to 3 Parkinson's disease, but her bone density was minus 5.1. And you can see here patient has L1 compression fracture. And my colleague performed the percutaneous vertebroplasty and increased the height of the anterior vertebral column. But 2 weeks later, patient come back to ER again because of severe low back pain. And you can see here retropursed bony fragment compressed the spinal cord. So my colleague performed the decompression and the short segment fusion with cement augmentation. However, patient has intractable hyperkinesia and dystonic motion, in truncal motions. Therefore, patients develop the new spine fracture, L1 right side pedicle fracture, and retropursed the pedicle screw. So we referred these patients to our functional neurosurgery colleagues to put the DBS, and after the DBS surgery, patients subside the hyperkinetic or dyskinetic truncal motions. And then my colleague performed anterior reconstruction. So therefore, from this painful experience, we can have some inspiration that even minor spinal disease, such as compression fracture, should be very carefully managed, and surgical decision should be differently considered if patient has a Parkinson's disease. So this is our aged population general characteristics in sagittal compensation and imbalance in the compensation. So when patient develops sagittal imbalance, patient develop the compensatory mechanism to restore the sagittal alignment, such as pelvic retroversion and knee bend and thoracic hypokyphosis and cervical hyperlordosis. As like these general ASD patients, the camptochomia is the severe sagittal imbalance in Parkinson's patients has a similar type of compensatory mechanism, such as knee bend and retroversion of the pelvis, thoracic hypokyphosis, and cervical hyperlordosis. Therefore, when we consider the deformity correction in this severe sagittal imbalance Parkinson's patient, we have to apply the general principle of the alignment, such as pelvic tilt less than 5 degrees, and the PI minus lumbar lordosis less than 10 degrees, pelvic tilt less than 25, and C7SV less than 5 centimeters, something like that. So generally, postural deformity in Parkinson's disease can be divided into 4 subtypes. according to the sagittal plane deformity and coronal plane deformity. The sagittal plane deformity is most famous one is the camptocomia, which is called the bent spine syndrome, as like figure A, which is affected at the thoracolumbar junction. And antecholis is so-called drop head syndrome, which is affected in the cervical and cervical-thoracic junction. Pisa syndrome is like a leaning tower of a Pisa. It's a kind of lateral flexion deformity, it's like in figure C, and scoliosis as well. There are many contributing factors involving to develop the postural deformity in Parkinson's disease. The muscular rigidity, axial dystonia, myopathy, impaired proprioception, and degenerative change in the spine. It's a little bit different from the other general degenerative ASD patients. Therefore, when we consider the surgical treatment in Parkinson's disease patient, we have to look at how much of these other contributing factors are involving to develop the postural deformity, and also how to treat these other contributing factors before surgical treatment. So I investigated the association of spinal deformity versus disease severity in Parkinson's disease. And in coronal plane study, we found that the coronal curve angle, the scoliosis curve angle, is strongly associated with higher UPDRS score, which means advanced stage Parkinson's disease, and higher coronal imbalance. Also, in sagittal plane, we found that the female and higher advanced stage Parkinson's disease, levodopa treatment, and the history of low back pain, all those parameters are involved in the development of sagittal plane deformity. Also, we can see the cervical deformity in Parkinson's disease can be explained that the extensor muscle weakness. So usually in general control group, if patient has a higher thoracic hypothesis, the extensor muscle compensation prohibit the forward drifting of the head, so less increase in C27 SVA. But in Parkinson's disease patient, the compensatory mechanism in extensor muscle is decreased. Therefore, the forward drifting of the head is significantly higher and compared to control population. So camptocomia is a flexible deformity, as like this gentleman, but patients can lie down flat in the bed, but compared to the rigid spinal deformity and ankylosing spondylitis patients cannot touch posterior part of the head when patients lie down on the flat. So surgical indication in camptocomia is important because the usually surgical outcome of the Parkinson's disease patients is not so favorable. So if patient has a marked disability due to the camptocomia, not from other Parkinson's disease symptoms, is an important indication. And the lack of responsiveness to the dopaminergic therapy is also important in surgical decision-making process. DBS is probably the most popular and famous neurosurgical procedure for Parkinson's disease. But compared to the tremor and rigidity, the spinal deformity cannot be easily corrected by DBS surgery alone. Because some patient has significantly improved by DBS surgery, but the outcome is very unpredictable. Therefore, we do not recommend the DBS as a first-line treatment for Parkinson's disease patients. Let me introduce my first experience of a good surgical outcome of DBS. this 60-year-old female comes to hospital with a quite significant PISA syndrome, so coronal imbalance. But when I saw her, a patient has a quite dystonic contraction of the ipsilateral lower back muscles. Therefore, I refer these patients to my colleagues in the functional neurosurgery and put the DBS in the contralateral STN. And the patients relieve not only the dystonic muscle contraction, but also improve the spinal alignment. So therefore, when patient has a coronal and sagittal imbalance which is derived from the dystonic muscle contraction, in such a case, we recommend the DBS first. Otherwise, DBS is not a good indication for spinal deformity patients. I'd like to share my camptocomia patients' experience. As this patient has a 10 years Parkinson's disease and Hoenya stage 1. So when start walking, patients can stand without supporting the trunk, but eventually patient need both hands to maintain or keep the sagittal alignment. So this is the sagittal 240 millimeters imbalance in C7 SVA, but when she is extended position, it's normalized to 23 millimeters. And so especially in as I told you, the camptocomia, which is affected at the thoracolumbar junction mostly. So when you look at the MRI scan, there is a significant muscular degeneration and fatty infiltration in the thoracolumbar area, but relatively well preservation of the lower back muscle in lower lumbar area. So after the surgery, patients can restore the sagittal alignment. And 1 year after the surgery, patient comes to my clinic without any significant complications and pain and disability. Patients can stand and walking without supporting both hands and satisfied with the surgical result. So patient can smile. So I think this patient is the first patient who Parkinson's disease who can smile. So it's very unexpected experience. So PISA syndrome is the lateral flexion deformity. It's defined as more than 15 degrees lateral flexion from the central line. And some patient has dystonic muscle contraction in the ipsilateral side. So in such a case, I recommend DBS or other medical treatment first. And if patient combine the myelo or radiculopathy, we recommend the surgical spinal surgery for relieving her symptoms. This lady has severe low back pain and leg pain, so she cannot stand by herself, and she has a truncal dyskinesia in postural imbalance. So severe marked coronal and sagittal imbalance, and L4 compression fracture, and the bone density was minus 2.6. And the patient has a severe stenosis. Probably the compression fracture and severe stenosis, the reason that patients cannot stand and the severe disability. So muscle biopsy shows the marked degeneration in the mitochondrial degeneration. And I performed the anterior posterior surgery and stabilize, especially in lower lumbar area, and correct the coronal and sagittal balance. So 2 years after the surgery, patient came to visit my clinic, and the patient did a cane assist, But and also patient has a slight trunk dyskinesia, but patient can tolerate pain and disability. Patient also satisfied with the surgical outcome. So outcomes of spine surgery in Parkinson's disease is considered generally less favorable, but the patients who has a successful outcomes can be predicted by short duration of symptoms prior to the onset of camptocomia and no motor fluctuation, which is suggested by Dr. Kohler in year 2010. In my personal experience from 2012 to 2023, I performed 20 cases of spinal deformity surgery in Parkinson's disease. And 40% of patients developed postoperative delirium, and the revision surgery was needed in 8 patients, 40%, mostly rod fracture and PJK. So success of spine surgery in Parkinson's disease patients depends on the interdisciplinary approach, including the movement disorder specialists such as neurologist, functional neurosurgeon, and the rehab specialist. Also, when we perform the surgery, appropriate correction of the sagittal coronal balance and strong biomechanical instrumentation, also obviously bone fusion is important. So I'd like to suggest this management strategy for Parkinson's disease management. So patients, first we look at whether a patient's disability actually came from the spinal deformity alone. Because many of the patients in Parkinson's disease have severe disability because of other Parkinson's disease symptoms. So we have to screen this kind of disability issue, then look at whether a patient has a myeloradiculopathy, and also investigate the functional performance, functional status of the patients. If all categories are indicated, long level decompression and deformity correction is required. The functional performance is not so good. Short segment decom and fusion for indicating the myeloradiculopathy. If functional performance is good and the myeloradiculopathy is another major issue, then we consider long deformity correction alone. The functional performance is not good. We don't need spine surgery. Also, short segment fusion is indicated in myeloradiculopathy patients. Thank you for your attention. I'd like to introduce the next year's Fall University Symposium in Seoul. The two Professor Kim. Kim is very popular surname in Korea. Host the next year's meeting. Thank you for your attention.